Okay, hi everybody. We have here some slides that we're going to go over. For anyone who wants a little more information about the lecture about esophageal diseases, we're going to kind of go through the slides here as I'm reviewing them and kind of hit on some of the maybe more in-depth points so we don't have to spend as much time during the lecture, and we can talk about some more fun stuff during the lecture. So I'm going to go one by one through the slides here. Try to describe each one so you don't necessarily have to be even watching this video while you're listening to it. So here we go. The objectives of this lecture are going to be to review the anatomy and physiology of the esophagus and discuss some major esophageal diseases that pretty much everyone as a med student should know. Things like structural diseases, GERD, motility issues, esophageal malignancy, and then some assorted other stuff. So very briefly through anatomy and some physiology, which you guys already are very aware of. We have the esophagus is composed of three sections: the upper esophageal sphincter, the body, and the lower esophageal sphincter. Remember, the UES, the upper esophageal sphincter, is striated muscle, so essentially voluntary muscle. So that's the part of the swallow that is voluntary, that you're initiating, that you sort of can feel occurring. There's a middle junctional zone, which is important in swallowing, about 30 to 40%, 35 to 45%, which is an overlap of striated and smooth muscle. And then we have about 50 to 60% the remainder, which is all smooth muscle, which is obviously involuntary. Here's another slide that's showing that a little bit depicted differently. Also going through on the right-hand side some diseases of the esophagus that affect different muscles. The vast majority of esophageal diseases, certainly in terms of motility, from GI perspective, are going to be smooth muscle diseases. Things like scleroderma, achalasia, and things like that. Then there are obviously a whole host of other things that generally tend to fall into more of the neurologic category that affect the upper esophageal sphincter and the striated muscle. Things like myasthenia, polymyositis, post-stroke syndromes, which are very common and lead to pharyngeal dysphagia, which we're not going to talk too much about today. But just keep in mind that that's a very important thing historically when asking people about their symptoms to get an idea of does it sound more pharyngeal dysphagia, where that they can't initiate that swallow, which might be more of a striated muscle problem, or is it more of a sort of dysphagia where they feel like the food is getting stuck or not going down, lower down in the chest. Here's a depiction of the esophageal wall. First thing that is important to know from an anatomic standpoint, which again you probably know already, is that the esophagus does not have a serosal layer. So there's a mucosal layer, which is involved in the epithelium, the basement membrane, lamina propria, and the muscularis mucosa. Then obviously submucosa and muscle layer. I did want to point out on the prior slide, remember the esophagus has two muscle layers, both a circular and a longitudinal layer. So if you can think of when the esophagus is squeezing with peristalsis, it's both shortening as the longitudinal layer is contracting and squeezing as the circular layer is contracting. So both are sort of happening at the same time. Here's another picture that I just put in this year, and something we're going to go over in the lecture, just showing the same depiction of the layers of the esophagus. However, this is what you would see when doing an endoscopic ultrasound, which is an endoscopic procedure which can be used, which is exactly as it sounds. It's an endoscope with a ultrasound on the tip, and it can perform ultrasound very finely on very sort of close-up areas. So this is showing the same thing as you would see the mucosa, submucosal muscle, and serosa in different parts of the GI tract, how it would look under endoscopic ultrasound. Here's a slide showing the innervation of the esophagus. Remember, everything, all the muscle layers need some sort of nerve innervation to work. So in this case, there are two plexi that are involved in the esophagus. There's the Auerbach's plexus. This is the bigger of the two. This is the one that involves the longitudinal and circular muscles, and it kind of courses between the two, and then has branches that go to the motor neurons in the muscle layers themselves to sort of stimulate contraction. And there's a smaller plexus called the Meissner's plexus, which innervates the muscularis mucosa. So the innervation, again, the smooth muscle esophagus, remember, as most of the esophagus, is innervated by both the parasympathetic and sympathetic neuron systems. It's mostly parasympathetic and vagal input. And there's both cholinergic, which is acetylcholine substance P, and non-adrenergic, non-cholinergic neurons. which are nitric oxide and vasointestinal peptide in this myenteric plexus. They are both innervated by different vagal branches, which I'll show you in the next slide. Very important to know in all of GI motility, essentially. There's a fairly simple sort of interplay going on between positive and negative and plus and minus. So pretty much all throughout the GI tract, acetylcholine is the plus, or it's the on sort of signal, and nitric oxide is the off, or the negative signal. So these two sort of signals are in balance in different parts of the GI tract, and that's essentially what causes peristalsis. And we'll go over that a little bit more in the next few slides. So this is a sort of depiction on this slide showing the innervation itself. So you have the brainstem, and coming down to the vagus nerve, there are two separate sort of tracks. One is innervating the positive, one is innervating the minus. So as you see, they both come down through the vagus, two separate nerve tracks. They both synapse on a postganglionic neuron, both with acetylcholine. Then there's a second neuron that goes from the ganglion to the smooth muscle, and that is where you have the negative and the positive sort of different branches. But you'll notice that the negative, which is the green on this slide, is all the way down from the vagus. It's sort of an isolated tract, as is the positive. They don't sort of mix. And why that matters is coming up in another few slides as to how that essentially causes peristalsis to work. So now, getting into physiology, we're talking about peristalsis. You guys all know about peristalsis. This is kind of the rhythmic movement of the entire GI tract as moving food along. Very important in the esophagus, obviously. As you guys know, with swallowing, there's both sort of peristalsis, which is the majority, and there's also gravity. So essentially, if you swallow a liquid, most of that going down is actually occurring from gravity. However, there's a classic story that everyone has heard. If you sort of lie upside down, or have someone sort of suspended upside down and give them something to drink, they will be able to swallow it, due to peristalsis, which is going to propel that into the stomach, no matter sort of which way gravity is forcing it. But with a liquid swallow, in a normal situation, a majority of that is actually occurring through gravity. So in primary peristalsis, this is following a swallow. The swallow is initiated voluntarily, and then is obviously propagated in a proximal to distal fashion, which we'll talk about, and can last up to 10 seconds. Secondary peristalsis is an involuntary peristaltic wave, which occurs through the neurons themselves to clear the esophagus of material. This, again, is involuntary. You don't know what's happening. You don't feel it, but it's essentially a clearing mechanism to sort of clear acid, food debris, whatever it might be, from your esophagus. Tertiary peristalsis is a sort of rare, non-propagating contraction. It's an older term. It can be sometimes seen in diffuse esophageal spasm, where the esophagus is sort of all spasming at once in a non-propagated way. I may have a slide on that coming up as well. This slide is probably the most important one in understanding peristalsis. This is a slide, if you're following along or if you're listening along, that shows on the left-hand side a depiction of an esophagus with a whole bunch of purple little spheres and blue spheres intermixed in the esophagus. And then there's a blue, red, and purple sort of tracing, which represents peristalsis on a manometry catheter. And then on the far right is a depiction of how the neurotransmitters are influencing that area of the esophagus. So to kind of explain, this is essentially explaining how peristalsis works. So we talked before about the positive and the negative inputs and the positive and negative neurons that are available in the esophagus. So as it turns out, there are more positive neurons, more acetylcholine neurons on the top, and more nitric oxide neurons on the bottom. So this is not by chance. This is to allow peristalsis to work. So when that peristaltic impulse comes down, all those neurons sort of are stimulated. The positive ones on the top, because there are more, squeeze first, and the negative neurons on the bottom relax because that they're more negative than positive. So that allows the propagation to start at the top and then work its way down as it's progressively becoming a higher concentration of negative on the way down. So the highest concentration of positive impulse acetylcholine neurons in the top. So when that impulse comes, it squeezes. And then the negative ones on the bottom, the nitric oxide neurons on the bottom, are staying open long enough, keeping the esophagus open long enough by that negative relaxation impulse to allow the propagation to come down. The question then becomes, why does it sort of squeeze at all on the bottom if it's negative? As it turns out, no one is exactly sure, but that negative impulse lasts maybe 5 to 8 seconds and then sort of resolves regardless of whether it's still being stimulated. So then that allows for the eventual propagation all the way down through the lower esophageal sphincter, because obviously eventually the bottom of the esophagus needs to contract as well to clear stuff into the stomach. But this is essentially how all peristalsis works. It's fairly simple if you can understand it. There's more positive impulse on the top and more negative impulse on the bottom. So when that impulse comes down, the negative impulse on the bottom allows, with the nitric oxide, allows for more dilation and allows the propagation to come down. Okay, here's a slide all by itself, which might mean it's an important point to know. Peristalsis is accomplished by a delicate interaction of excitatory, being acetylcholine, and inhibitory, being nitric oxide neurotransmitters. So the lower esophageal sphincter is that junction, obviously, between the esophagus and the stomach. It's composed essentially of both esophageal muscle as well as the diaphragm, which kind of are intermixed to allow for that sphincter. When this swallows, the inhibitory pressure input increases in the lower esophageal sphincter and essentially opens the LES for anywhere from 6 to 8 seconds due to that negative impulse. During multiple swallows, this is called deglutative inhibition. During multiple swallows, the lower esophageal sphincter remains inhibited until the last swallow. Think about if you're sort of just worked out or really thirsty and you're taking sort of a drink of water and you're drinking 4 or 5 or 10 swallows at a time. If peristalsis was occurring, you wouldn't be able to do that. It would sort of the water would hit up against a occluded lumen and you wouldn't be able to swallow. So once that swallow starts, if you have multiple swallows occurring at once, in succession, the esophagus just stays open and inhibited until the last swallow, and then the propagation occurs. Transient lower esophageal sphincter relaxation is essentially this event where the lower esophageal sphincter is opening. However, it's not related to a swallow. It's happening without a swallow, and this is one of the main causative agents of reflux. It lasts longer than a swallow-induced relaxation, so essentially it's an opening of the LES that's allowing gastric acid to come up and is not related to a swallow. And then obviously after the swallow, there's a phasic contraction which allows for the LES to close again to not allow all the intragastric contents to come back up. With increased abdominal pressure, retching, or sort of bending, or anything that's increasing your intra-abdominal pressure, the tone of the LES will increase also, again, to prevent material from coming back up into the esophagus. Next, we're moving on to some structural things. Hiatal hernia. You've all heard of a hiatal hernia. Many patients are very proud of their hiatal hernias, and they'll come and tell you, 15 years ago someone told them they had a hiatal hernia, and will tell every physician they can find about their hiatal hernia. It's a very common finding we see all the time. In the vast majority of cases, is not a significant medical issue. The definition is a herniation of viscera, most commonly the stomach, into the mediastinum through the esophageal hiatus of the diaphragm. There are 4 different types. By and large, type 1, which is a sliding hiatal hernia, is most certainly the most important one, or the most common one, where the fundus and cardia of the stomach are just slipping up into the diaphragm, through the diaphragm, into the intrathoracic cavity. So that serves to lower the LES pressure because that tight junction is not there anymore, and can increase reflux symptoms. There's a type 2 hernia, which is a paraesophageal hernia, which I have a slide coming up which will show to depict that. And this is when the fundus sort of slips up next to the LES. So the actual LES is intact, but there's a piece of the stomach that's now slipped into the thoracic cavity sort of next to that. That can be a little more dangerous. Those can sometimes get incarcerated. Sometimes that's more of a surgical indication. Type 3 is when both are happening, both of these things. I've never seen that. Type 4 is not really a hiatal hernia. Type 4 is when any other organ sort of herniates through the diaphragm. There are some congenital things you may have heard about. One is called a Morgagni hernia. One is a Bachtelek hernia. These are things congenitally when infants are born, and like the colon has herniated up through the diaphragm and things like that. Almost always these require fairly urgent surgical correction in infancy. Here's a slide just showing that what I'm depicting. Again, the sliding hiatal hernia versus the paraesophageal hernia, which are by and large the two most common that we see. Some endoscopic pictures. I'm going to spend a little more time during the lecture about the pictures because this is a little more fun, so I won't describe them too much here. This is a first picture showing essentially a normal lower esophageal sphincter during endoscopy. The second picture is showing a sliding hiatal hernia, and the third one here is showing a paraesophageal hernia. A structural ring, we see this not infrequently. A ring is a sort of acquired area of narrowing, usually in the lower esophageal sphincter, right above the G junction. Occurs in older individuals. It's been described as the steakhouse syndrome. This being because many times people will complain of intermittent dysphagia to meats when they go out for steak or meat or some heavy meal. That being obviously because it's, those heavier foods, meats, tend to get stuck because they don't get chewed as well. And again, this can happen every week. It can happen twice a year. And patients are usually fairly consistent with saying it doesn't happen unless I have, certain heavy meals. And treatment is via endoscopic dilation, which we'll show you. This does not have to be dilated. If patients have one and they're comfortable with it and it doesn't bother them too much, there's no medical reason to have to do it. So the only reason to sort of treat this endoscopically is for convenience or sort of patient comfort. Esophageal web is a proximal mucosal constriction. Not all that common. When given years past talking about this, giving this talk, I've said I've never seen one. I'm fairly certain I may have seen one, maybe two this year, since last year. However, there is a entity which I'm sure this is a perfect med student question because people love these obscure things. Something called Plummer-Vinson syndrome, and this is when you have an esophageal web in association with iron deficiency anemia. Because med students are always very astute and on top of things, I'm sure someone's going to ask me why this occurs, why these two things go together. I have no idea. I've tried looking it up. There doesn't seem to be hold too much information as to why esophageal webs and iron deficiency anemia would sort of coexist. Okay, here's some, again, endoscopic pictures showing a Schottky or esophageal ring. Here's a picture showing dilation of said ring with a endoscopic balloon. Here's a picture showing another way to dilate anything in the GI tract. Really, these are called savory or bougie dilators, which are progressively sized plastic dilators, which are tapered and can be used as well for dilation. Okay, there are three types of diverticula that occur in the esophagus. By and large, the most common one here is the upper esophageal diverticula, known as the Zenker's diverticula. There's also epiphrenic, which can occur rarely in, for instance, achalasia or a stricture, and that's due to the increased pressure. So a Zenker's diverticulum occurs in older patients, a lot of times in men, due to weakness of the muscle fibers of the upper esophagus. Again, essentially not a surgical emergency, does not necessarily require surgery, unless you have patients, as we do now at the VA, with sort of chronic aspiration. If it's so big and causing significant medical problems, that might require surgery. But if nothing else, it's for sort of symptom control. And this is an ENT doctor would usually do this procedure. There are now some ENT doctors who are sort of venturing into doing endoscopic closure of Zenker's, whereas rather than doing an open neck dissection surgery, they sort of using endoscopic tools go in and sort of staple it closed essentially. And certainly that's potentially a better option minimally invasively if you have an ENT surgeon who's comfortable and familiar doing that. There are mid-esophageal diverticula, which are very rare. I've never seen one, which is classically in the textbooks talked about in relation to tuberculosis. The idea being you have some mediastinal scarring that's sort of pulling the esophagus out. And then an epiphrenic diverticulum, again, occurs in the lower esophageal sphincter, just above it. This is due to some disease state that's causing increased pressure, either a stricture or achalasia, at the bottom of the esophagus, which is causing that pressure to sort of bow out because it's years of pressure pushing against a narrowing. There is a entity called a cricopharyngeal bar, which is not a diverticula, but sort of doesn't belong everywhere else. And this is, again, a sort of structural muscle problem where you get a constriction of the UES from a muscle bar to cricopharyngeus. Here's a picture showing a Zenker's diverticulum. Here's a picture showing a epiphrenic diverticulum. Here's a Google search that I was doing showing a very funny picture that Google shows you in relation to GERD. And GERD is a big issue that we're going to probably spend some time during the lecture talking about, so I won't spend too much time here. Up to 15% of patients are affected in the United States with GERD. The diagnosis is defined as troublesome symptoms or complications attributed to gastroesophageal reflux of stomach contents. Purposely, probably very vague. Reflux itself is a normal physiological event. You're supposed to have reflux coming up into your esophagus, which is then normally cleared by that secondary peristalsis we talked about. However, if you're having abnormal reflux or symptoms related to it, that constitutes GERD. And some risk factors, hiatal hernia, as we talked about, the integrity of the LES is decreased, obesity, older age, and possible genetic components. We talked again before about that transient lower esophageal sphincter relaxation. It's a non-swallow-induced relaxation of the LES. It commonly lasts longer than a normal LES relaxation and allows for gastric material to come up and is an important causative factor of GERD. Classic symptoms are reflux and heartburn. Heartburn is not abnormal. Having heartburn intermittently when you're eating certain trigger foods is not necessarily GERD, and it's not abnormal. Almost everyone at some point in their life has had some sort of heartburn. And then there are atypical symptoms like chest pain, dinophagia, and dysphagia. Chest pain being a big one. That should obviously always assume to be cardiac in nature first. And there are some extra esophageal symptoms, cough, laryngitis, asthma, which we'll talk about a little bit in the lecture. Laryngopharyngeal reflux in relation to the ENT doctors and the GI doctors is usually a hotbed of contention. And then NERD stands for non-erosive reflux disease. This is most people with gastroesophageal reflux disease actually have NERD, meaning when an endoscopy is done, you don't actually see any evidence of erosions or things like that. It's important to sort of mention that because many times we'll be asked to perform endoscopy for patients with heartburn symptoms, reflux symptoms. The consult will say rule out GERD, and sort of it's important to make sure you know why you're doing that procedure, because a good majority of people are not going to have any endoscopic evidence of reflux. Unfortunately, during an endoscopy, we don't see sort of reflux coming up into the stomach, into the esophagus. So we do talk a minute or two about the indications for endoscopy in GERD. Here's a picture of a normal G junction. Here's a picture of esophagitis. On the bottom, you'll see there it says LA grading. Los Angeles class grading goes from A through D, and this is how sort of inflammation of the esophagus is graded. You do not need to sort of know what A, B, C, and D exactly are, but it certainly would be nice for you guys in clinical rotations to at least be familiar with knowing LA kind of class criteria, LA grading for esophagitis. A obviously is the most benign, and D is the most severe. Okay, so how do you kind of diagnose GERD? Again, in 2013, which is the most recent guidelines we have from the American College of Gastroenterology, they advocate for empiric trial of PPI therapy, meaning for 2 weeks, you give someone a PPI. If they're better, you can sort of make an empiric diagnosis of GERD. And then the role of endoscopy is to evaluate for esophagitis and to evaluate for complications. So that's why we're doing it. The endoscopy in GERD, again, this is a study that was done many years ago, sort of almost 30 years ago now. 220 patients with symptoms of GERD, and only about a 60% positive predictive value of heartburn is a symptom of confirmed GERD. So the conclusion here was EGD findings are a poor marker for GERD, as we discussed briefly. Here's an important slide. Again, so there's two sort of criteria from different two guidelines, from two different societies. 2008 from the ACG, is a little less specific. It says to do an endoscopy with troublesome dysphagia, or if they're not responding to twice daily PPI therapy. And 2013 is from the American Gastroenterology Association. A little more refined, presence of alarm symptoms. Alarm symptoms we'll go over in the lecture. Screening in patients at high risk, we'll go over for that certainly. And non-cardiac chest pain. Importantly, there's no indication for repeat if it's normal. So if it's normal during the endoscopy, you don't need to keep doing it over and over again, like screening for colon cancer, for instance. Here's a picture of Ashley Simpson. We'll talk about why we have that up. Complications of GERD, erosive esophagitis, stricture, Barrett's, and esophageal cancer. This is why you're doing an endoscopy, to look for any or all of these to try to sort of prognosticate and take care of these early. We'll talk a little bit about PPI therapy in the lecture, but just suffice it to say, since the advent of acid treatment and PPI therapy, the sort of incidence of things like we're looking on this next slide, strictures and such, are dramatically decreased. This is a picture of an esophageal stricture. This is a picture of a stricture versus a ring to see the difference. Sometimes, presumably, you can get the two confused because they both sort of affect the lower esophageal sphincter, but you can see clearly the difference in terms of the length of these entities. Okay, Barrett's is something that's very important that you're going to hear about, going to know about. It's sort of ubiquitous. Essentially, this is a change in the squamous cells of the esophagus from squamous cells, to intestinal cells, not gastric cells, intestinal columnar cells. That's called metaplasia. My very basic sort of description to patients is that after years and years of sort of being assaulted by acid, the squamous cells of the lower esophagus sort of give up and start to turn into intestinal cells, which are sort of designed to deal with acid. The concern is that obviously this eventually could progress through into esophageal cancer, and that's why we screen for Barrett's and surveil for Barrett's. Older white males are at the highest risk, which is why those are the patients usually more likely to get screening endoscopies in the setting of GERD. Treatment with acid suppression long term, there's no great data that says it's going to decrease the rate of progression to dysplasia, but the guidelines, including the ones that recently just came out, do continue to recommend acid suppression with PPI therapy for Barrett's. Another slide all by itself. Barrett's esophagus is a precancerous lesion for which interval surveillance and follow-up is recommended. Here's some pictures showing Barrett's that we'll go over. Here's another picture showing Barrett's that we'll go over. Here's some new sort of guidelines just from a few months ago. This is important. You can read for yourself here, but this is important in that up until November of this year, the recommendation was if Barrett's is discovered, you should have a repeat endoscopy in 1 year for follow-up. The guidelines now have sort of gone away from that, now saying clearly if you have initial Barrett's esophagus without dysplasia, the risk of progression of that to cancer is so low, you do not need to do one in 1 year, and you can do it in 3 to 5 years instead. Here's a picture showing a subtle thing. If you miss it, called a little esophageal nodule. Again, we'll go over the pictures more in depth in the lecture to make it more fun. And here is showing some therapies that can be done for these things. Okay, so mainstay of treatment for GERD is acid suppression, and PPI therapy has shown dramatic improvement over H2 blockers, which are obviously older therapies. Things like ranitidine, famotidine, things like that. Lifestyle interventions are commonly advocated. There's limited evidence for improvement. The recommendation here is really to tailor recommendations to patient symptoms. There are some very classic ones, about elevating the head of the bed and avoiding caffeine, avoiding citrus, avoiding all these different foods. If there are certain triggers that cause reflux, definitely you should stop it. If you notice that your reflux is only happening at night, raising the head of the bed will help. But this is not something that we sort of should be recommending universally for every patient to do all of these myriad interventions. And the surgical option is a Nissen fundoplication, which we'll show you. 1997, so this is now 20 years ago, still not recently, but a meta-analysis showing healing erosive esophagitis, clearly showing that PPI was 84% heal rate versus 52%. And here's a slide showing data as well. that the same study showing that by 2 weeks, 30-ish% of patients were healed already with PPI therapy, and clearly throughout all of the weeks up to week 12, PPI therapy led to the best healing of esophagitis. Esophagitis is an entity where the recommendations continue to be you should recommend sort of lifelong or long-term PPI therapy. The traditional teaching has been up to 85% of patients, if stopped on PPI therapy, the esophagitis will come back. Why do we care about esophagitis? Because if you leave esophagitis alone, it very commonly can lead to strictures. As I alluded to before, the rate of strictures that we've seen recently compared to pre-PPI therapy is dramatic. And the reason for that is, everybody with reflux now is on PPIs. And that's significantly decreasing the rate of reflux and acid and subsequent complication. Here's a slide showing all the things that have been advocated at some point for treatment, lifestyles to remove from your diet. Again, none of these need to be done unless these are specific triggers for the specific patient. Here's a slide showing a Nissen fundoplication and how it's done. We'll go over it in the lecture. Here's some slides showing results from 2007, a recent study, showing essentially that over the course of an 11-year follow-up, which is a fairly significant follow-up, patients' status-post Nissen fundoplication did show sort of durable response. Okay, moving on to another entity, eosinophilic esophagitis, something becoming more and more common. You guys are certainly going to hear about this. It's most likely an allergic or immune response to food and aeroallergens. It's classically young Caucasian males with atopic diseases like eczema or asthma. Symptoms are dysphagia, food impaction, and chest pain. They're characteristic endoscopic findings, which we'll show you. They're diagnosed with a biopsy finding of at least 15 eosinophils per high fiber field. And treatments with acid suppression, food avoidance, topical steroids, and allergy consultation. Food avoidance tends to be more effective in children. Here's a slide showing both endoscopically and histologically what you're looking at. Another slide showing a more severe evidence of eosinophilic esophagitis with stricturing. Here's talking about motility issues now, moving along. There are a number of diseases related to altered peristalsis. In esophageal motility, the majority of patients with motility sort of disorders or complaints will have sort of these non-specific diseases. The best thing to know about esophageal motility is on any test is really only two or three things they can ask you about, because there are only 2 or 3 entities that are studied enough and have enough kind of clear criteria to discuss. So the main one by far in esophageal motility, the main thing to talk about is achalasia. Then there's diffuse esophageal spasm and scleroderma. And this is usually always confirmed with an esophageal manometry, which I'll show you in a few minutes. This is a depiction of a manometry. A manometry is essentially a catheter that's inserted through the nose like an NG tube. Patient swallows it while they're awake. They have to be awake for this because they have to be able to interact with the examiner and perform the procedures. And then during multiple swallows throughout the test, this catheter is a pressure transducer, and it's recording pressure readings at different different levels, I should say, of the esophagus, and giving a reading as to peristaltic waves. This slide is showing you essentially a very basic depiction of what a normal peristalsis should look like on a traditional manometry. On the top, you have a spike from the pharynx, and then you have a very quick negative deflection, which is the UES opening and closing very quickly. Notice at that time, if you go all the way down to the bottom, that's the LES, which is opening and staying open the whole time. Then you have that propagated sort of spike moving down through the 4 levels, and that's the peristaltic wave. Then on the bottom, you have the LES closing again. And we'll go over this a little bit in the lecture also. Achalasia is the classic sort of motility disease. It occurs in 1 in 100,000 people, presenting in sort of people in the middle age group, 30, 40, 50, 60-year-old ages. It's due to a probably autoimmune loss of ganglion cells, and it preferentially affects the inhibitory neurons. Going all the way back to those first slides about the peristalsis, the problem is, for some reason, that the autoimmune system is attacking those inhibitory neurons, which leaves only the positive acetylcholine neurons. So the swallow is not happening because there's no negative to open up the lower esophageal sphincter. It's important to know that this is a neurologic process, not a muscle process. So achalasia is not a muscle problem. It's a neurological problem. That's not sort of the nerves are getting destroyed, not the muscle. The symptoms include dysphagia to liquids and solid. This is important, and chest pain. And then there's secondary achalasia. This classically occurs with Chagas disease for the same reason that after being infected, the body creates an immune response to that, which also preferentially attacks the lower esophageal sphincter neurons. And pseudoachalasia. Pseudoachalasia, I have a picture of it, is essentially some lesion, classically a pancreatic mass or some sort of intra-abdominal mass right around the LES, which is pushing from the outside, essentially a tumor squeezing the outside of the lower esophageal sphincter and causing what looks like achalasia, but is actually a tumor that's not allowing it to relax. Diagnosis, again, of achalasia by manometry and or barium swallow. Some very classic barium swallow pictures, which I'm going to show you. Endoscopy is really secondary. And there is a higher risk of a squamous cell carcinoma seen in achalasia. In the last 10 or so years, probably more, there is a new manometry catheter available, which most people are now using, which is called a high-resolution manometry. It's a much different picture and gives much more information. And subsequent to that, in doing procedures on patients with achalasia, the experts have discovered there's actually there are three different types of achalasia, where in the past we only knew of one. And that's the classic achalasia, which is a lack of peristalsis. There's diffuse compression, where there's this kind of mild compression all the way through. That's the best one to treat. And then there's spastic achalasia, which is just a spasm of the majority of the esophagus. That's very difficult to treat. This is a classic picture. I'm going to talk about it in the lecture, showing achalasia esophagram. Again, showing the same thing. This was actually subtly showing pseudoachalasia, and she is asymmetric. So, if you lose all your inhibitory neurons, then the manometry, what's classic for the manometry of achalasia is that you should have a hypertensive LES and impaired relaxation. You can also get a lack of peristalsis when all of those neurons get destroyed, but most importantly, the LES has to be hypertensive, so it has to be a higher pressure than normal, and it does not relax. Those are the two very classic things for achalasia to make the diagnosis. Here's a picture showing, which we'll go over in the lecture, showing what a high-resolution manometry looks like. You'll see it looks dramatically different. It's actually fairly easy to interpret once you get the idea of it, which we'll spend some time sort of talking about. Here's showing classic achalasia. Notice all that blue in the middle there where there's no propagation at all. And then the one on the bottom, C there, showing spastic achalasia, that big magenta sort of mountain, which is a big pressure spike, which is obviously not peristaltic. Treatments for achalasia. There are some medical treatments for limited benefit, nitrates and calcium channel blockers. By and large, treatment is either surgical or endoscopic. Botulinum toxin can be injected because, again, it blocks acetylcholine. So by blocking acetylcholine, you're allowing that relaxation to occur. That is a sort of temporary solution. It's not permanent. At best, you might get 5 or 6 months out of it. And then balloon dilation, which we'll talk about. And then the surgical treatment is a Heller myotomy. And there's a fairly recent study, not so recent anymore, in New England Journal sort of showing that these two, balloon dilation versus surgery, are equivalent in terms of outcomes. Diffuse esophageal spasm is another entity. Symptoms of dysphagia and chest pain. Manometry reveals simultaneous contractions with normal LES relaxation. And then there's something called, there are limited treatments for this. And then nutcracker esophagus, which is a manometric diagnosis of a very high amplitude sort of spike of pressure. The scleroderma is a classic disease of hypotensive LES. So scleroderma is a smooth muscle problem. There's no peristalsis anywhere. The LES is loose. There's no muscle tone anywhere. The main difference between this and achalasia, again, this is above your level, is that in achalasia you can have a manometry look exactly the same, but the lower esophageal sphincter is going to be hypertensive. In scleroderma, it's hypotensive. That's the main difference. Another slide, last one all by itself. Dysphagia is the primary complaint in motility disorders. Structural disorders present with progressive solid food dysphagia, And motility disorders present with dysphagia to both solids and liquids. That's important. Here's three famous people that I'm going to really hope you guys know who they are. Okay. Esophageal cancer is an important thing to know about. The risk is on the increase. As I told you before, the Barrett's esophagus is sort of increasing, mainly due to increased obesity and older age in the American population, which is then subsequently increasing the risk of esophageal cancer in America. Squamous cell versus adenocarcinoma. Many years ago, it used to be that squamous cell was more common. Now it's certainly that adenocarcinoma has taken that over because of the Barrett's progression. Progressive dysphagia and weight loss are the sort of symptoms. The known etiological factors are listed there: alcohol, tobacco, caustic injections. There is sort of description of people who have lifelong sort of ingestion of very hot liquids, hot teas, over years and years and years. This may actually increase the risk of squamous esophageal cancer as well. We talked about achalasia doing that. Head and neck cancers can do it. Nitrites and nitrates in certain foods over years. There's no reliable way just by history to determine versus squamous versus adenocarcinoma. You have to take a biopsy. Adenocarcinoma has to be in the lower esophagus in some area of Barrett's, some area that has changed to a non-squamous cell lining. And it's more common in Caucasians, males, and the obese. So generally this is diagnosed when someone comes in with a symptom of dysphagia. Generally that will lead to either an radiological investigation or an endoscopy. Doing the endoscopy allows for biopsy to be taken. And once it's diagnosed, there's sort of more involvement in terms of imaging and staging. Unfortunately, esophageal cancer is not a good cancer to get. This being adenocarcinoma. Squamous cell carcinoma is sort of more easily treatable with radiation. But esophageal adenocarcinoma is not a good disease to have. But very small minority of those patients are resectable or curable at diagnosis. And there's only a 5% 5-year survival reported. Here's a picture showing esophageal stent, which we'll talk about. Some new addition this year, some new esophageal things to talk about. This is esophageal varices in the setting of someone who has cirrhosis or portal hypertension. Again, some pictures of varices there, which we'll talk about. Esophageal infections, we'll just talk about very briefly. The majority of esophageal infections are due to Candida, and you get herpes and CMV. Candida is the one that you do not have to necessarily be immunosuppressed to get. The other two, herpes and CMV, are almost always in immunosuppressed patients. Candida, very commonly we'll see it almost incidentally on endoscopy. People who use oral steroids or inhaled steroids, especially COPD patients and things like that, asthma patients, things like that. Here's a picture of a Candida esophagus, as we talked about. If someone has symptoms of Candida esophagitis, has odynophagia, pain in swallowing, on an oral exam they have thrush, you can sort of just treat empirically and see if it gets better. And these can be biopsied or brushed and pretty easily diagnosed. This is showing herpes esophagitis, again, almost always this and CMV occurring in patients who are immunosuppressed. AIDS patients and or people on chemotherapy and things like that. Pill esophagitis commonly occurs in the elderly. It's due to these medications listed on the right. Tetracycline, which is no longer available. NSAIDs, bisphosphonates, which are used for osteoporosis. Iron supplements, quinidine, and potassium. That's a big one that people will be taking. Presents with odynophagia, and treatment is essentially stop the medicine and let it heal on its own. Rumination syndrome is a fun kind of thing to talk about. Rumination syndrome is someone will come in complaining of vomiting, but if you take a better history, they're actually regurgitating. These carnival sort of workers who are swallowing things and regurgitating them back up. They're not vomiting. It's sort of rumination. It's called rumination syndrome because it's like a cow who's eating and sort of bringing it up back and forth. And these patients many times through life sort of figure out on their own how to sort of deal with it, and sort of they bring it back up into their mouth and they re-swallow it. And this is treatment is behavioral. Again, but it's just something to think about, especially young people, people maybe with associated anxiety or mental health issues, that they may not actually be vomiting when they say the chronic vomiting, that it may actually be this. So you have to take a clear history. Some fun pictures to show. This is called an inlet patch. These are some foreign bodies. We're going to go over another foreign body, and lastly a foreign body there. So hopefully this was a little bit helpful to kind of go through the slides for you guys and give a little more input into some of the more academic things that are here. So feel free to sort of take a listen. My email is here on the first slide, christopher.lenza, Lenza, @va.gov. Send me an email anytime if you have any particular questions. And we're going to see how this works. And I'm going to try to spend a little more time during your lecture tomorrow, kind of going over some fun stuff and maybe making it a little less dry. So hopefully this will be well received, and we'll see you tomorrow for the lecture.